coming up today. It's a shining example of the importance of knowing your family history and being proactive in your health. And it's what two sisters attribute to them being alive today. Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. It's the ongoing journey of two sisters who have always been inseparable. Josie and Jordan grew up sharing everything, but they never dreamed they'd wind up sharing the same diagnosis.
We're 15 months apart. We played on every sports team together. We've gone through college together, all of the things. So we've always been best friends, so close.
Sisters Josie and Jordan Wooderson so far have done it all together, the good and the bad.
We said after our weddings and after our cancer, we're gonna be like bored. What do we do? You know, just I guess enjoy.
This is why I have my sister. She helps me.
These two are embracing life.
She does everything girly for me. Yeah. Who are those girls?
And taking nothing for granted.
The sky is more blue, the sun shines brighter.
That's because in 2022, Josie, a nurse, felt something was off.
I had noticed a spot in my breast. I had had it checked out, and then about a year and a half went on, and I noticed it changed.
She was referred to the University of Kansas Cancer Center. Test results would later confirm Josie, at just 26, had breast cancer.
Of course, my mom and dad and my sister came straight over. You know, from day one, I was like, okay, we don't have a choice. We have to fight this. We have to go through with it. And you have to go through it to get through it. That was kind of my motto through the whole thing.
Their grandmother also had breast cancer. So amidst doctor's appointments, treatment plans, and chemo, Josie decided to take control of what she could. She met with a genetic counselor at the cancer center.
Found out that I was BRCA1 positive, which then triggered the rest of our family to be tested.
Which of course would include her sister Jordan, who tested positive for the gene. Just a few months later,
We didn't want to believe it, but in the back of my mind, when I saw the abnormal lymph node on the scan, you know, the spots I weren't worried about. A lot of women have benign spots, but when I saw the abnormal lymph node, I was like, that's not,
especially
that's not
knowing
typical.
our genetic and the fact that I had already had breast cancer, and we knew the odds, the statistics were not in our favor.
They were right. This would be another thing the sisters would share. Jordan also had breast cancer.
It was
The same as mine.
malignancy, yeah, invasive ductal carcinoma.
After 6 rounds of chemo and a double mastectomy, Josie is in remission and considered cancer-free.
See a red bird.
There was one on the fence.
She's also back to work and able to support her sister as she begins chemotherapy, which will then be followed by a double mastectomy.
But they're growing.
Yep.
But first, it will be a walk down the aisle for both.
We love flowers, making bouquets.
Right now, these two are way more interested in talking wedding plans than chemo appointments.
It's almost indescribable, really, our relationship now.
I don't really think there's anything in the world that could come between us at this point.
Not a chance. Well, this morning we are so happy to have Josie and Jordan with us, along with breast surgical oncologist Dr. Kelsey Larson and Dr. Laura Nye, a breast oncologist and medical director of breast cancer prevention, both with the University of Kansas Cancer Center. So glad to have all of you here with us.
Thanks for having us.
So excited. I've been waiting to have you two back here with us and doing well, I take it?
Yes, very.
Jordan, just some really exciting news. So lots of exciting news to talk about today. But first, just tell us where you are with your treatments.
I officially finished chemo on October 6th. It was a very exciting day. Dr. Nye got me through it all. And so I'm almost a month out, feeling great. I already feel like I have some energy back and feeling more like myself. Following up this coming Tuesday, Dr. Larson will be performing surgery. And after that, just healing and then radiation to follow. I spoke with radiation oncologist the other day, and then some more treatments, immunotherapy with Dr. Nye. So a lot to go, but a lot behind me too. So feeling really good.
That's a great way to say it.
Yep.
Josie, you've been declared cancer-free.
Yes.
That is the greatest news. What's it like to be back to work as a nurse, right?
Yes. I've worked in labor and delivery for 6 years, and I think it's just always been in me to like want to help people, and so I guess being here, I kind of actually feel like I fit in because I kind of understand very different worlds, but you know, there's a lot of similarities just in healthcare in general. So I guess also being a nurse, you know, when Jordan was diagnosed, it was kind of my instinct to just want to help her, like probably too much some days.
I bet.
But I wanted to do anything possible to help her and to get through, and I think that's kind of how, you know, our mentality was and what helped us stay positive through it.
That's just what you do
Yeah.
as sisters.
That's right. Yep.
Okay, so we got to get to this good stuff off the top. Jordan, when we spoke, you were engaged at the
Yes.
time.
Yep.
You got married just last weekend.
Yes.
What was this big milestone like for you?
It was a very actually relaxing day. I know that people think weddings are stressful, but for us, it was like a day we didn't have to go to chemo or a cancer appointment. So actually, it was very relieving to just be with my friends and family and have everyone I love in one room at once. It was pretty meaningful. I think, you know, sometimes people get caught up in, you know, the decor and all of this and everything, but for us, it kind of had a different meaning this year. And I'm pretty thankful to have a husband who knew of my diagnosis and is sticking with me through it all from the beginning. So in sickness and in health was taken very seriously early. So we've started off on a pretty good foot and have a very strong relationship.
We say those.
Yep.
You're tearing up already?
Yeah.
You guys are so sweet and so cute. I mean, I tell you what, these two are just so wonderful patients. And I actually remember when you were diagnosed because you were coming back for follow-up visits.
Yeah.
So I think I heard about it from you and from my team.
Yes.
And so it sort of feels like I'm just saying I'm part of their family because they are just
You are our second
We've said
family.
that.
this year.
We've said like in the last, because it's been almost a year and a half since our whole journey started with you guys, and it does, like, you truly have become part of our family, and it's like a home away from home.
Right.
Like oddly
We
enough,
don't mind it though because we know that you're saving our lives. You
Yeah.
know, it's
Are you bringing Kleenex? Yeah, Anthony, come in. Oh, come on in, Anthony. Yep.
when I
Thanks,
got my
Anthony.
wedding
There you
photos
go.
back from the photographer, I immediately was sent to every doctor, you know, because every nurse, every doctor knew the wedding's coming up, you know, and they just know, and hers too in April. So it's like they know and care about very personal parts of our lives besides just the cancer.
I think like our very
means a
first
lot.
conversation with Dr. and I was, okay, she's got a wedding in October. How are we going to get her to this?
We had some bumps, but
You did great.
Yeah.
you made it.
Beautifully.
Well, and Jordan, what I loved about your story, and for both of you, you said a lot of women or people would say, I want to wait till after my treatment. I want to wait till my hair grows back. I want to wait till I have more energy.
Right.
And you said, I don't want to wait.
No, let's do it.
Let's do
'Cause
it.
You never know.
You never
just,
know.
You know, you live differently every day, and to us, we've kept, you know, every chemo, we planned my wedding, and
We knew Jordan and Joe were going to get married before, like, even before I started. So it would have been April of 24. They weren't even engaged yet. And I found out, and I think like the day of or the weekend of, I was like, can you go ahead and like get engaged and get married
can have
already so
something
that I can be there and make sure that everything's okay?
yeah.
So again, no big honeymoon because you got this double mastectomy coming up next
Yes.
week.
Yep. Next fall, we're planning our honeymoon. So we have
Okay.
it planned and we're ready. So hopefully healed up and no problems by
Ready
then,
to
and
go.
we'll be good to go.
So I want to go back a little bit. Josie, when did you first, because this all really started with you, when did you first discover that spot on your breast? You knew something was wrong, but you're a nurse, you knew something was a little off.
Yeah, so I think it was August of 2022, I had noticed a spot, and I was actually on birth control for quite some time and decided that I was going to get off of that, and I noticed it started to change. So then about a year and a half after that, so the spring of 24, I asked my providers again, hey, can we look at this spot again? Is there any way that we can get scans? And they're like, yeah, absolutely. I work alongside them, so you know, we trusted each other in that judgment. And It was pretty large. The surgeon at our local hospital told me, you know, you can remove it, biopsy it, or we can leave it alone. And I don't know, something in my gut just said, let's get it out. They were confident that it was benign, but the way it felt and the size wasn't really matching up with some of the imaging that they had. So they did a needle localization prior to surgery. And they found some additional spots when they did that ultrasound. So I had the images and I had to go back, and part of me knew. I went back in the holding room and my parents were in there, and I could hardly even talk to them because I think I knew in that moment. Everybody had been telling me, it's fine, it's benign. And for some reason I told people, I was like, well, probably, but until we have the pathology, we can't be sure.
You just
I don't know,
had some
gut feeling. I kind of had it, you know, knew that something wasn't right.
Dr. Nye, I mean, 26, I mean, to have a gut feeling of breast cancer, I don't feel like we're supposed to have a gut feeling of breast cancer at that young age. So, I mean, what percentage of patients that you treat or that you know of are diagnosed that young?
The diagnosis of breast cancer under 30 is pretty rare. Depends on the study you look at, less than 1%, less than 4%, but many young women are ignored or told it's benign or it's a cyst or it's related to your hormones. And so it's really unusual to have that gut feeling and to be persistent until it grows, and usually tends to involve lymph nodes at a young age, just because we don't think about breast cancer in 20-year-olds.
Was that gut feeling there because your grandmother had breast cancer?
I don't know, my family calls me weird. I always told them I had this gut feeling that I was gonna have cancer someday. Like, I can't explain that, and it sounds insane to most people. I had a cancer policy at work at 26 years old. Like, most people don't think of that. So I don't know what it is. We just had a strong family history of cancer in general. And so I think being a nurse and just knowing, you know, just having that knowledge, I was like, I can't let this go, because the odds of it being something are slim, but what if it was something? And so that was kind of my mindset, and I was like, let's get this out. I don't want to have this in me. So the spot that actually was going to be removed was benign. There was just cancer around it that hadn't been seen even 6 weeks prior in the ultrasounds and scans that they had done.
Smart woman to get that checked out and ask more questions. Dr. Knight, how would you explain invasive ductal carcinoma to someone with no medical background?
So a cancer cell is just when our normal cell learns how to grow uncontrolled, and so it can grow and grow and grow, and that's what cancer is. In our breast, we have many different types of cells, and the ductal cells are the most common to develop breast cancer, and they're what line those tubes that milk can flow out of. So ductal carcinoma is when one of those ductal cells that lines the tube learns how to grow uncontrolled, and that's cancer.
Dr. Larson, how does a medical oncologist giving chemotherapy coordinate with a surgical oncologist who then does the operation?
Yeah, that's a great question. So every person who has breast cancer needs a team of folks to care for them. Every person would need a medical and surgical oncologist, sometimes, as you mentioned, a radiation oncologist too. And the idea is that Dr. Nye is really a biology expert. She knows the biology of the cancer. She knows the best medicine for a particular biology, so medicine is really based on that biology. Surgeons are really anatomy experts, right? So we need to know the anatomic area of cancer. We need to understand the options for anatomically removing it, but it's that teamwork that gets people the best outcomes. So a little bit different ways we contribute, I think, to people's care, but certainly all part of the team in terms of going for cure.
Josie, you were told you had locally advanced triple negative breast cancer. What did you understand that to mean at the time?
So my pathology results came through on my chart. I'd woke up from a nap. I actually told everybody, like, please go home, I'm fine. And I woke up from a nap Friday afternoon, and it was like my eyes, there was like a magnet to those words, invasive ductal carcinoma. And I knew, I was like, searching, I was like, surely this is like a control saying like negative or something, you know, and I was like, no, that's it. And so in that moment, I just knew, like, I have cancer and I have to go find somebody who can help me. That was pretty much my mindset. My family all, like, they all came over Instantly, my coworkers came over and we laughed. It was the weirdest thing, but we sat there and we laughed and we're like, we're gonna get through this.
I heard it was Jordon making a lot of jokes.
Yes, we thrive on dark humor.
Thrive on dark humor. Okay, we like that around here.
To get through it, yeah.
Yes, I think we were driving to town that weekend and we passed the sheriff and Jordan's like, it's okay. Tell him you have cancer and you're distraught. Like, you're fine. It's gonna be okay.
I think that's a fair excuse.
Yeah, I think that's 1,000% fair excuse.
I think this is a good excuse.
Funny.
We use that sometimes more than we should.
Use it, go for it, for sure. Dark humor is good, and you need it, Dr. Nye, when you're explaining to a patient that you have triple negative breast cancer. I mean, how do you explain that to a patient, really so they can understand what they're up against?
I'm a picture person, so I usually draw it out. But a cancer cell, a breast cancer cell specifically, we know to look for 3 different what we call receptors. And if you're in my clinic, I describe it as arms on a cancer cell, like hungry, hungry hippo, binding up what it needs to eat. And so the estrogen receptor and the progesterone receptor bind hormones, and that's what helps the cancer cell grow and drives the growth. The HER2 receptor that we look for is a tricky one that can just bind to itself and make the cell grow. But when all of these are missing, that means we have a really smart cancer cell that knows how to grow without being fed by those different things that we have drugs to turn them off. So that means we have to use things like chemotherapy and immunotherapy to target those cancer cells.
And Jordon, you were extremely lucky, doctors say, because your tumor was 4 millimeters in size, about the size of a popcorn kernel, I understand. It was already in your lymph nodes. You're younger, of course, than the recommended age to get a mammogram.
Yeah.
I take it you had never had a mammogram before.
I mean, I'm, 10 years from, I was 26 at diagnosis, so what's recommended, 35 or 40? Yeah,
40.
So I wouldn't have made it to what was supposed to be my first mammogram without Josie's diagnosis.
Without her diagnosis leading to the family history component to all of this. Dr. Larson, how important is the family history?
Yeah, I think family history is really critical, honestly. It's important for all of us to understand that family history isn't deterministic for what happens, right? So just because a sibling or a relative has something does not determine that we will have it. But that family history and speaking to your doctor about it, that's really how we can have options to keep people safe, right? So we know in medicine some of the red flags where we might need to look into things further, like the genetic testing, different screening approaches, things like that. Dr. Nye does a lot of great work even for patients who are not genetic positive to try to work on their risk of breast cancer and keep track of them. So that family history really helps us as physicians to understand what a person needs to tailor the screening and the care to them and really try to personalize the best outcomes for every person. So
I have a question. So she's diagnosed at a young age, just like her sister, Josie. She learned she has the BRCA gene. I'm curious kind of what that was like, and what her surveillance would have been like over the years, assuming that she wasn't just a few months later diagnosed. Is that pretty typical? I mean, is it
No, this is not a typical
That's what I'm
story.
saying, is that, was it because she has a sister who was diagnosed young, or?
It was because of the BRCA1 mutation, the BRCA mutation. We usually start screening at 25.
Okay.
And with her sister's history, we would actually consider starting someone even younger than 25. But we went ahead and started her screening, and I'm just proud that she got it because I've had young women who are like, no, I'm getting married. We'll do that right after. And there wasn't a big mass. There wasn't a big tumor. And so screening was critical.
So she could have held off the family history component, the genetic screening component. Is that what you're saying?
Both of her age and the BRCA1 mutation were critical to having Jordon show up to get the screening.
Everything worked out perfectly here.
Yes.
So explain the surgical process on why you operate on the breast and the lymph nodes when you're doing breast cancer operations.
Yeah, sure. So our goal in doing the breast portion of the operation really is to remove the primary tumor site. We know that cancer can spread. Cancer can spread through the blood. Cancer can spread through the lymphatic system. So for most patients, the first spot outside the breast where we would see an area of cancer if it was looking to go outside the breast is in the lymph nodes. And so when we do surgery, we want to both get rid of the area of cancer, the primary spot in the breast, and we want to assess to see if the cancer is misbehaving and starting to go to those lymph nodes. That impacts a lot of things in terms of keeping people safe in the future, including what's done from a medical and radiation standpoint.
Be sure to ask your questions. Use the chat on YouTube or Facebook. You can email the Medical News Network. That information is there on your screen. So you two basically do everything together. Explain kind of the timeline from diagnosis to treatment. What was different and what was the same?
I had my mastectomy first, and well, actually, we both did IVF. We both did egg retrievals, and then I went into my mastectomy the same day as my egg retrieval, actually, and then I had chemo following that, and then some revisions and surgeries during that time frame and afterwards, which is kind of backwards from Jordan's.
And the reason why she had her mastectomy first is because it was not advanced to any other areas. It was local to her breast. And mine, like she said, was a little bit backwards because mine had already spread to armpit lymph node, and so the plan of treatment was to kill the cancer first and then remove the breast. So a little bit backwards, but
We're still going to end with the same results.
right.
Yes, exactly. Interesting.
Yep.
And why is that? I mean, again, it's not one size fits all, right? I mean, everybody is looked at and exactly the same end result, but two different paths.
Yes, we really personalize breast cancer care. It depends on the size, the lymph nodes, the markers, and treatment has advanced that in some situations it's helpful to give the chemo and immunotherapy first and see the response, because then I can tailor any treatments we need after surgery based on that response in the breast.
I want to talk about family planning. You brought that up. Jordan, you and your husband did IVF.
Yes.
Also, because you mentioned you did it, Josie. You have 6 embryos. Tell us about those embryos. You told me some information about that. I think that's interesting. I want to ask the docs about that.
Yeah. I mean, going into this, we knew that we were told, both of us, that IVF would be a good plan, just in case, our bodies did not return to normal after chemo. So we both did egg retrieval, and we went ahead and created embryos, like you said, in which we got 6. And we did go ahead and go through genetic testing for the BRCA gene to try to stop that. So we tested all of them. 3 are BRCA positive, 3 are BRCA negative, but we plan to use science to help us try to end this horrible gene. So for family planning, we will use, the negative embryos for implantation to have children. So that's our plan in the future.
I just didn't know if people knew that you could, genetic test even.
We didn't know
early.
that.
Yeah,
I
didn't know.
It's
people do that.
amazing what science can do for
It's
you.
called pre-implantation genetic testing, and it is available now. And so a lot of young women are afraid to have children because they've gone through breast cancer at a young age and they don't want to see their offspring do that. And for those women, this is a great opportunity to think about pre-implantation genetic testing.
Josie, what are your plans? And when's your plan down the aisle?
April. April is our date. We will also do the same. We will do IVF. I just did an egg retrieval prior to my chemo, but plan to do another round of IVF and egg retrieval and embryo creation in December or January, one of the two. So coming up.
Well, I want to get to some questions from our viewers this morning. And Joe Ellen and Marcia both saying best explanation of triple negative I've ever seen. Saying I've never heard triple negative breast cancer described as a smart cancer that knows how to grow without being fed. That's such a great explanation. So thank you for laying that out for our viewers and listeners. Jeremy asked, why are the ducts such a common place for cancer to develop?
They're a common cell in the breast tissue, and some that change over a woman's lifetime, especially as we go from puberty to breastfeeding. There's a lot of change in a woman's breast growth that we feel every month with our cycles, and during that time cells are turning over.
Julie wants to know, can the cancer come back in other places in the body even after a double mastectomy?
Yes. So that is my job, is to make sure that cancer doesn't come back anywhere else in the body. I always tell my patients, your surgeon will make sure that they do the best surgery possible to get rid of the cancer in the breast, but all this chemotherapy and all this immunotherapy is to get rid of cells that could have escaped the breast so they don't show up later as metastatic cancer.
Jeff wants to ask Dr. Larson, do you recommend a double mastectomy for anyone who tests positive for the BRCA gene?
Sure, that's a great question. So patients who are BRCA positive who do not have a cancer diagnosis would usually be eligible to do what's called risk-reducing mastectomy. So that's a bilateral mastectomy which helps to lower a woman's risk of cancer. It can lower it as low as around 5% in her lifetime, so a significant risk reduction. For women who have a cancer and have one of those genes, they are at elevated risk for a second cancer in their lifetime. So some women do choose to do a bilateral mastectomy as part of risk reduction. Some women choose to be followed closer with increased screening. So that decision is a little bit shared decision making, but certainly the bilateral mastectomy helps to lower the risk of a second primary cancer.
Jordon, Josie, thank you so much for sharing your story today. We're so glad to have you both with us. Jordon, I just want to start with you. What do you want the big takeaway for those watching and listening to be?
I would say just some things for people to know is that one important thing we both kind of realize is that people think that when you ring that bell, you're done. That you're done for the rest of your life with it, but you're not. I rang the bell the other day, but I've got a surgery ahead and radiation and several months of immunotherapy to follow well into next year. So still lots of treatment left, and even when you are done with treatment, you still have to think about it every day, and you have scans and blood work, and we have more to think about with our children and other risk-reducing surgeries because we have the BRCA gene. So I want to be positive about this. When I say we're not done with it, but we learn how to live with it and do happy things and get to live in. That's why, we didn't delay the wedding. We just wanted to keep going and doing fun things in life because life doesn't stop. You have to keep going. So,
Such a great
Yep.
great message.
Yep.
Josie?
I've said many times in the last month, with it being Breast Cancer Awareness Month, and constant reminders and people asking and saying you're so brave, and that's true. But life doesn't stop at diagnosis. So while it might seem brave, it's us living our life still. We have weddings and families and such happy times in our lives, and I think sometimes we would go to appointments and they'd be like, are you guys really okay? Because we're doing all of these things still and enjoying life, and I think that that's important to know as someone going through any type of cancer. We're still humans, we're still us. The diagnosis doesn't take us away.
There's
we're
hard days,
still
behind the scenes that
Sure.
there's plenty of tears and anger and asking why, but for the most part, we've done a pretty good job at keep moving along and keep going.
Just keep going. You can do it.
You ladies
you
are
have to just know you can do
have
it.
such a great spirit. To be continued.
Yes.
Because we want to keep
Yep.
following your
Yes.
story, because
Yep.
you got lots of life to
We
live
do.
and lots of babies coming
Yep,
and lots of
that's
fun
right.
stories to share. So it's just so great to have you. What a great way to wrap up Breast Cancer Awareness Month. Dr. Nye, what's the big takeaway from this story?
First, these are some of the most inspirational women I've ever met. Grace is one of my favorite words, and they truly just embrace that. So I just want everyone to know how amazing and stoic you ladies are. I don't think I ever saw Jordon without Josie there, and that is so helpful to someone going through cancer treatment, to have a person there, both for the patient but for the care team. I mean, we know that if Jordan's having a problem, Josie's going to call us. So we're not really. Yes, that is typically how it went. So just having a person, be that person for somebody. And knowledge is power. Josie didn't get tested or say, hey, you need to go get checked, I don't know how advanced Jordan's cancer would have been.
Dr. Larson.
You know, I think what both of them shared is the importance of being proactive, right? And a lot of what I hear from you guys is you can't change what happens to you, but you can be proactive about those things, right? So being proactive and speaking up when things seem off, being proactive and getting the testing and doing the screening, not putting it off for a year or two because you got other things to do. I mean, this is really the example of that, right? So people who are proactive cannot always prevent things, but we can catch things early. We can have absolutely the best outcomes, best life and things like that because you're partners with us in doing that, right? I can get you from your house and make you come in and do the things you have to do. Proactive patients are amazing because you guys are just the people who do well. You're the people that we can really help, honestly.
Ladies, thank you for your story. Docs, thanks for your amazing expertise as always. Thank you for being here. And thanks to our viewers for joining us. And we end with a few reminders from our friends over at Poison Control. A reminder that your medicine can look like candy. Always lock up your medicine, especially now because children are in candy mode, as we know. Everything looks like something pretty tasty. And don't forget about your furry friends, all your pets. Chocolate is toxic for dogs. Watch those candy bowls. And finally, we say goodbye with some adorable trick-or-treaters right here from the health system. These are our patients from radiation and oncology. They got a jump start on trick-or-treating earlier this week. Everyone, please have a very happy and a very safe Halloween, and we will see you back here next week. Coming up Monday on the Morning Medical Update, diagnosed with colon cancer at just 27 years old after years of misdiagnosis. I'm Jessica Lovell. On the next Morning Medical Update, we share how Jackson Layton is taking it one day at a time, combining clean living and aggressive treatment. Monday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stein's podcast. Now everywhere podcasts are available.